Good afternoon, dear network. It's 14:30 and I think we can start. We have about 78 participants on the call. I welcome you to this week's tele-echo session. I'm Dr. Lungwebungu, your facilitator for today. And we'll be looking at a very interesting topic where we'll be looking at management of unsuppressed viral load in children. Dr. Victoria Manzi, our pediatric HIV coordinator under Lusaka province, will take us through the didactic presentation. We do have other experts on the call, such as Dr. Rachel Thomas, and we have other experts that will later log in. That's Dr. Muya, Dr. Charlie Lwechungu, Dr. Chimika Piri, Dr. Fubisha, and Dr. Mwate Mwambazi. All these experts will be able to attend to your questions that you can post in the chat box as well as during the question and answer session. Assisting us with IT today is going to be Chatonda, and Kunda is going to coordinate our session. Thank you once again for logging into this session, and we'll begin. So we'll start with Dr. Manzi's presentation, then we'll go into a question and answer session. Dr. Manzi, over to you.
Thank you so much, Dr. Lungwebungu, and good afternoon, dear network. So today we'll discuss management of unsuppressed viral load in children. I have no significant financial conflict of interest to disclose. So our objectives for today's tele-echo session are three. The first one is we are going to highlight the causes of high viral load in pediatrics. We are going to discuss the strategies for improving viral load suppression among children. And lastly, we are going to discuss considerations on treatment failure, that is genotyping and ART optimization. So to start with, to end AIDS as a public health risk, the Joint United Nations Program on AIDS, UNAIDS fast track approach has set a target of 95 of all people living with HIV. That is 95% of those infected with HIV should know their status. 95% of those with HIV should be started on ART, and 95% of those on ART should be virally suppressed by 2030. Once we attain this, we will potentially reduce the new infections by 95%, thereby providing an opportunity to end AIDS by 2030. The aim of ART administration in children is to achieve viral suppression and to halt the disease progression. At the same time, reducing opportunistic infections and eventually morbidity and mortality. Viral load suppression, VLS, as we'll see in the presentation, is an essential parameter of ART effectiveness as a surrogate marker for disease progression.
So we do have our first poll question. Is this statement true or false? By the end of Q4 of 2023, Zambia had achieved 95% viral suppression among children 0 to 14 years. Is this statement true or false? By the end of Q4 of 2023, Zambia had achieved 95% viral load suppression among children 0 to 14 years. Okay, I'll allow a few more seconds. We're about 53 of us that have voted. Okay, I'll allow us to reach at least 65%. Okay, you can end the poll, IT, thank you. Okay, so most of us think that the answer is false. That's about 65%. And we have 35% that think that the answer is true. And we'll get to know during the course of the presentation. You can proceed, Dr. Manzi.
Thank you so much, Dr. Lungwerungu. So in Zambia, despite substantial ART coverage in people living with HIV, over the years, we have seen that viral load suppression in HIV positive children, 0 to 19, receiving ART remains low. And as at end of Q4 2023, so this is Ministry of Health data, we were at 85% viral load suppression, much lower than what we are seeing in adults. So this is the picture as at Q1 2024. And you can see, according to the age group, among the children 0 to 4 years old, the viral load suppression was at 77%. For children 5 to 9 years at 85%, and for children 10 to 14 at 89%. When you go further to look at the provincial picture, you can see how we are performing according to our respective provinces. So we are seeing Luapula at 77.4%, Muchinga 77.2%, followed by Northern Province at 79%. I think those are the lowest that we have. And then the highest that we have, as you can see, is at 87%, 87.6%, that is in Central Province, and 86%, 86.7% in Lusaka and Eastern Province. So you can see that among children receiving ART services, according to the data that we have as a ministry, virus suppression is ranging from 77% to somewhere at 86%, much lower than what we see in the general population.
So we have our second poll question. The following can contribute to unsuppressed viral load in a pediatric client. A, poor adherence. B, drug resistance. C, toxicity to the ARVs. D, caregiver knowledge. E, all of the above. The following can contribute to unsuppressed viral load in a pediatric client. A, poor adherence. B, drug resistance. C, toxicity to ARVs. D, caregiver knowledge. And E, all the above. Okay, so far most of us are leaning in one direction, and we have at least 65% of our participants that have polled. I'll allow a few more seconds. Okay, so we can end the poll now. So about 92% of the network think the answer is E, that's all the above. And we still have a small percentage that think drug resistance, that's 1%. Poor adherence at 4%, caregiver knowledge at 3%, and none of us think toxicity to the ARVs is a factor that leads to unsuppressed viral load. So we'll also get to know what the answer is as we go on with our presentation.
Thank you so much. So when we look at some of the things that can cause unsuppressed viral load in children, we have poor adherence at the top of our list. We know that children rely on caregivers to take their medication. So it's also a reflection on the support that this child receives. That's why at the initiation of ART and every time we review, we have to assess adherence. And in so doing, we're assessing the caregiver who provides the support. Drug resistance could be another. So this is in a case where a child acquires a resistant bug. Maybe they were exposed to ARVs in the case of EMTCT. So this can cause unsuppressed viral load. Toxicity to ARVs is another reason that can cause unsuppressed viral load. And being young, young age, for example, children below the age of 5, I think in the next coming slides, we'll talk about children below the age of 5. Their immune system is immature and it's not able to mount an immune response towards the HIV. Thereby, they are not able to reduce the viral load as quickly as an adult. Caregiver knowledge, this one is very key again. It's also related to the first one because we have children being taken care of by elderly caregivers. We've had situations where a grandmother, elderly, is not able to follow instructions. They don't really understand the importance of giving the medication at the right time and which medication. If you've noted, currently in our facilities, we are giving, for children, we are giving ABC 3TC and DTG in a separate container. So we had a caregiver who was giving ABC 3TC. She would finish all the bottles and then she would start the DTG afterwards. So we realized that every time you told her to come to a facility with a bottle, she would come with more DTG because she was only giving ABC 3TC. Once it finishes, by the next appointment in the next 3 months, she would still have drugs. So caregiver knowledge is very critical in attaining viral load suppression in children. So there are some factors that can also contribute. So what we've been discussing are causes, but there are also factors that can contribute. So for children less than 5 years, they have the following factors, compounding their viral load suppression ability, the low immunity for children less than 5. So children who acquire HIV below the age of 5, usually they struggle with viral load suppression and they take a bit more time to achieve viral load suppression. Variability in ARV pharmacokinetics. So for children, you find that maybe the way they metabolize the drugs compared to an adult, it's different. So you find that they are able to metabolize the drugs more quickly in their bodies than adults. So that can also affect the ability to achieve virus suppression. Pre-treatment HIV drug resistance, like I said, due to exposure of some ARVs as part of PMTCT. So we are using AZT, 3TC, NVP. So if a child is exposed to those drugs, possibility that when they are started on those drugs or related drugs, they may have resistance, adherence problems. We've already talked about them, and also them depending on caregivers all the time. In addition, there are other factors I think that have been shown in studies that have been done in other countries in sub-Saharan Africa. There was a study that was done in Tanzania that revealed that food requirements for some regimen affected the ability of the child to achieve viral load suppression. I think previously we were using drugs, the PIs that would require that maybe food is given at a time of drug administration, confidentiality around the HIV status of the child. So we've had situations like in our Zambian setting, when a mother delivers, they may go to their mother's house to deliver, or a mother-in-law may come and they're assisting in the care of this child. And then this child is diagnosed with HIV, or even just a prophylaxis. You find that this mother will not be confident to have these people around because they've not disclosed their status. So they don't give the drugs for fear of stigma and discrimination. Say, this young child is being given ARV. So that really affects the ability of the child to achieve viral load suppression, because the drugs may only be given when the mother is alone, but in a household where you are living, a lot of you've gone to your in-laws' place, it may become difficult. Non-disclosure is another. So we've seen that non-disclosure, especially among the young adolescents, 10 to 14, is one of the leading causes of viral unsuppression. So the moment this adolescent who could have been living with HIV as mother-to-child transmission discovers, especially accidentally, they discover that they are taking these drugs for HIV, they just stop taking the drugs. So non-disclosure really is a big issue among the adolescents. And I've seen we are struggling much more with our adolescents when it comes to viral load suppression than the younger ones. Because the older adolescents, you find this child is being told, go and take your drugs. They are trusted with the drugs. They go in the bathroom and flush the drugs. So we've had all those issues. Forgetfulness by the caregiver could be a factor that can contribute. So we have caregivers who just have, memory issues. And so in counseling, we have to provide them with support of reminders and all those things of how they can remember to give the drugs. It's actually more difficult for those caregivers who are HIV negative. For those who are living with HIV, they can match the time of taking their drugs with that of the child. But someone not living with HIV, it may become difficult because of routine and things like that. Lack of transport to the facility to bring the child. So missed the appointment means the child is not taking the drugs. And if someone is not taking the drugs, you can't achieve viral load suppression. So there are some strategies that we can use to correct and improve viral suppression among children. So a number of strategies have been shown to improve viral load suppression in children, looking at the gaps, the factors that can contribute, and the causes. So first of all, correction of the regimen and the doses. How are they giving the drugs? Is this the correct dosage? We'll discuss further. Then screening for opportunistic infections, age-appropriate disclosure, EAC, DOTS, and case conferences.
Okay, so we have our third poll question. Upale is 11 years old and has been on ART for 9 years. He has a viral load of 4,500 copies per mil. During enhanced adherence counseling, he tells the provider he is not sure why he has to take medication every day. Which of the following strategies will not help Upale achieve viral suppression? Is it A, continue enhanced adherence counseling with the caregiver? B, refer him to a support group? C, use DOTS? D, screen for opportunistic infections? So take note that the question is asking which of these options won't help Upale achieve viral suppression. Which one of them will not help achieve viral suppression in this scenario? Should you continue EAC with the caregiver, refer him to a support group, use DOTS, screen for opportunistic infections? Which of these options will not help Upale achieve viral suppression? Okay, so we have, unfortunately, most of us haven't yet polled. We're only at 33%, so I'll allow more time for us to poll. We have a network of 260, and I only have 116 that have polled. Please, network, take a go at the question so that we know what we should emphasize on during the presentation. We are only at 55%. I'll allow a few more seconds. Let us at least reach 60%, then we can end the poll. Okay, great. So we can now end the poll. So most of us think that screening for opportunistic infections will not help Upale achieve viral suppression. Okay, we still have at least about 15% that think continuing EAC with the caregiver won't help. We have 15% that think referring him to a support group won't help, and 10% think using DOTS won't help. So we'll get to know during the presentation which of these will not help achieve viral suppression.
Thank you so much. So before the poll, we had looked at the strategies for improving viral load suppression among children. But the poll did confuse a lot of people because it was which one will not even though they were listed before, you'd still get confused because you don't know what really to apply and what not to apply. But now we'll discuss, the first one said correcting the dosage and the regimen. We need to correct inappropriate regimen and also dosage for the weight based on the dosing chart. We have national guidelines. You go in a facility to find they're still using the odd, dosing charts with ABC 3TC being given BD, okay? And yet we've moved. So if you've complicated the regimen for the child, becomes complicated for the caregiver to give. In the morning, give ABC 3TC. In the evening, give ABC 3TC plus DTG. Now it's combined. So let's use a new national guidelines and the updated national tools. So we need to make sure that we're doing the right thing and adjust the dosage. So for children, the dosing is according to the weight. So if a child has increased in weight, they may move from one weight band to the other. So body collection, we do not encourage that. We want to weigh the child, if possible, at the facility. That's why for children below the age of 5, they come to the facility more frequently. For the under 2, it's actually monthly because their weight just doubles anyhow. Their weight increases. So let's correct inappropriate regimen. So this is a baby, you start them on ART, they are below the age of 2. You can't give 3 months. You need to see them every month so that you can adjust the dosage. Screening for opportunistic infections. Let's screen for opportunistic infections. Background of opportunistic infections, if not treated, may lead to someone failing their ART. So we know the most common opportunistic infections. At every visit, we are screening for TB, and also if they are negative for TB, we initiate prophylaxis. TPT initiated every 3 months, every 3 years. And we also have septrin for those that are below the age of 5 and those that are newly diagnosed, okay? Disclosure, like we said, it's one of the reasons why adolescents are failing their treatment. So here we're talking about age-appropriate disclosure as per national guidelines. And in addition, development of the child. So you find there are some children, they are 12, but developmentally they're behaving like they are 5. You wouldn't disclose the HIV status. So the two have to go hand in hand. So we have partial disclosure. We start by the age of 5, 6 to 8, then full disclosure by 9, 12. These are adolescents now. They are going to the adolescent support group. By the time they are joining the support group, they should have achieved disclosure. You can't send someone who do not know their HIV status to a support group. The moment they discover that the reason they are going to that support group is for HIV, believe you me, they may interrupt their ART. And that was a scenario for Bupali, who did not know why he was taking ARV. So you wouldn't send him to a support group. It will not help him achieve viral load suppression. And that was the secret. Completion, we want to make sure that these adolescents, by the time they're 13 to 15, will have achieved full disclosure. They know, and they are able to come to the facility, collect their drugs on their own. So the next one is enrollment into a support group and other DSD models for children living with HIV more than 10 years. Here, I've put 10 years because by 10 years, we are hoping that they would have known why they are taking the drugs. This is following caregiver disclosure of the child's HIV status to each one. So they know why they are going to a support group. We've seen children go in a support group and they don't know why they are there. They were just told by their caregiver that you need to go and attend the meeting at the facility. EAC. We saw that adherence is a problem and major contributor to unsuppressed viral load among all recipients of care. So it's recommended for all with a viral load at or above 1,000 copies per mil. So recommended 4 to 6 sessions. So the first one is included as well. When you get the results, then you have 3. Then after that, you can repeat the viral load within 90 days. So if you are doing them every 2 weeks, you have 6 sessions. If you are doing them every month, you have 4 sessions. During EAC, we look at the barriers that are hindering optimal adherence to ART, and we find a plan. We come up with a plan that is tailored to the child's unique needs. So there's nothing that is A, B, no. We look at the barriers and address them. So if the barrier is forgetfulness, we are going to say, let's set up a reminder system. So we come up with the plan for the child. DOTS. So DOTS stands for Directly Observed Therapy. The child is observed as they take the medication, either by a community-based volunteer or a caseworker. In the case of maybe OVC services, we have caseworkers who go in the community, or a family member who's trusted with the HIV status as a caregiver. So here I'm talking about a family member within the household. So I had a child we took care of at Matero. This was a 4-year-old living with the mother and the grandfather in the same household. So he himself was 4 with a high VL for almost 2 years. His mother also had a high viral load. Okay. So I asked her, do you have someone in the household who knows about your HIV status? Said, yes, my father knows my status and the status of the child, who's a grandchild to this man. So I asked if they could come, and we discussed, and he agreed to support them. So he was the one now giving the drugs. Okay, so he knew about the status, that was okay, and he was not going to disclose to others, because the fear is disclosing to others and stigma. So you have to identify a caregiver within the household who can keep that status and also support. Within 3 months, we had achieved viral load suppression for that family with support from a family member. So DOTS has been shown to improve adherence to treatment and eventually viral load suppression. So in the case of a case conference, we have seen that case conferences are being used now for children with a high viral load. So here, this is where you have a formal multidisciplinary meeting involving service providers from different fields involved in the care of the child. So the meeting is usually organized to discuss difficult cases, a child with persistent viral load, and then you want to find solutions. So who attends this case conference? So you have representation from the clinical team. So you can have a nurse, a clinician. You also have the caregiver to the child. You have a caseworker, okay, or a CBV. So why we have a caseworker or a CBV? We want these team players to provide the community perspective on factors that may contribute to non-adherence and non-suppression. They go in the field, they go in the household. A caseworker goes in the household to do an enrollment and a home visit. So they understand the home setting where this child is coming from. So they may say the reason why this child is ending up with a high VL, which you've seen as a clinical person, is because the child is not being given medication because of lack of food at home. So the community perspectives include lack of caregiver support to the child's treatment, religious and traditional beliefs and practices. So they may understand where this child is coming from, and they are able to give that feedback. So we've looked at some of the strategies that we can use. Now, after we've done all that, how do we manage this child with a high viral load? Okay. We all know that patients on ART with treatment failure are at risk of progression to HIV disease. Adherence barriers must be evaluated and corrected before the therapy is changed. Before you can just say, okay, let's change the treatment, we have a high viral load. We address the barriers through EAC. Even in a case conference, there are barriers that you can identify and you address them. Let's evaluate for opportunistic infections, especially TB, before we change the therapy. What are some of the considerations for ART treatment failure? So EAC is conducted, we repeat the viral load. If it's still more than 1,000 copies, despite optimal adherence, the child should be switched to second line. At the time of switching to second line, we collect blood for genotyping as per national guidelines. So it's at the time when we are switching, we also send blood for genotyping. ARV regimen can be changed once the genotype results are received at the facility. It's highlighted, do not delay optimizing the ARVs by waiting for genotyping results. There are children who have had a high VO 2 years. We are waiting for genotype results, okay? That should not delay the decision to switch to second line. So let's focus on genotyping. What is genotyping? So it's a test that informs a clinician on the type of HIV drug resistance mutations, and it also helps them select appropriate drug therapy. So when you do the genotyping, they tell you the virus is resistant to ABC. So choose this medication instead, which will work. So only collect genotype from patients who have completed EAC and still have a high viral load. So at the time of collecting for genotype, you collect another sample for viral load. When it goes to the lab, they will do both. So you find that some of those results they are waiting for genotyping, when they did the viral load, it was suppressed. So they did not proceed to the genotype. So we need to make sure we have a system to follow up the genotype results. Optimize second line after genotype results, like we said. Genotyping also helps us as a country and as a program with HIV drug resistance surveillance, and it will prevent unwarranted progression to salvage therapies. We can't afford to have a lot of people on third line, very expensive. So we have to make sure that we are doing the right thing. So it will only be done on patients on DTG, those that have failed on DTG or PIs and have completed EAC with a repeat viral load more than 1,000 copies per ml. And it must be performed on recipients of care who have evidence of being adherent to ART for at least 30 days. So someone should be taking the drugs. If they are not taking, then you really can't develop resistance. What are you fighting? So the virus will only develop resistance if someone is taking. So we had a child, genotype was done, had a high VO for almost 2 years. Genotype was done. The results came back. All the drugs were susceptible. It only meant that the child was not taking the drugs at all. So resistance only develops when someone is taking. They take, they stop, they take, they stop. Then the virus will develop resistance. And it should not be done on recipients of care who are not currently taking ARVs, even though viral load is high. So someone has to be taking some ARVs somehow. Why should we switch? What are we trying to achieve when we switch? We want to achieve HIV virus suppression. We want to achieve immune reconstitution, improve the clinical status of the child, avoid adverse events, including death. Young children progress very fast to advanced HIV disease if they're not on treatment, and eventually they die. We want to optimize adherence, prevent accumulation of mutations and cross-resistance. Second line, what choices do we have? So depending on the first line that is used, we are given preferred second line. This is from the considered HIV guidelines. And this is a table that we should have in our facilities. So for 0 to 4 weeks, first line is AZT, 3TC, NVP. So within 4 weeks, we don't expect someone to fail their second line. So as you can see there, it's blank. But in case you find such a case, you may refer or call experts, you consult. For children, more than 4 weeks and more than 3 kg, we know the regimens that we're using. We are using ABC, 3TC plus DTG. If they fail this regimen, then you will take them to AZT, 3TC, plus lopinavir, ritonavir. For those that are on ABC 3TC plus lopinavir, ritonavir, you switch to AZT 3TC DTG. So you can see we are just, if DTG in first line, a PI will be in second line. If the PI is in first line, the DTG will be in the second line. For those that are on CAFED, the second line is AZT 3TC plus lopinavir, ritonavir. And then we have those that are on TDF. I think we'll talk about the wet bands. So we know that the darunavir, ritonavir has been recommended for those who are more than or equal to 12 years and are weighing more than 40 kg. Yeah, so you can see darunavir, ritonavir coming through there. And also there's alternative second line. There are people who would say they react to darunavir, ritonavir, or there are other reasons. We have alternatives in the last column there. And if you are not sure, please, let's consult. We have a line there, 7040, where we can make a phone call and we'll be guided. So when should we consider, or what should we consider before switching therapy? We've said we switch at completion of EAC, but there are some things we need to consider. Poor adherence, okay? Change therapy only after enhanced counseling has been conducted. IRIS, if the client was started on treatment, within 6 months, they develop IRIS. At 6 months post-treatment, you do a viral load, it's still high, okay? They still have opportunistic infections which you did not treat. Think of treating those underlying conditions and then continue ART if related. Untreated OIs, we've said that. Pharmacokinetics, let's also consider other drugs that we could be giving. We know that when we are treating TB, we adjust some dosages, okay? We know that rifampicin will reduce the dosage of DTG that we are currently using, so we have to double dose and things like that. Let's make sure that we are doing the right things, especially when it comes to double dosing. If you make that mistake, you may be the one who's causing the viral unsuppression because they will have a small amount of DTG in their blood to fight the virus, but you're treating your TB. So finally, I want to talk about low-level viremia. I think the other week we had another discussion presented by Dr. Seville. This was talked about. I just want to emphasize that we also have children who may have a viral load hovering between 20 to 100 copies per mil. They are not above 1,000. They are just, they are not undetectable, but they are just hovering there. They never settle, okay? Evidence really, there's WHO guidance, but I think the guidance that we are looking at is for those with a viral load more than 200, there is associated virological failure. So you may need to consider them for EAC. That's the guidance, okay? We need to monitor them closely and conduct EAC for those that have a viral load more than 2 copies, because we know that if they persist like that, next thing you find that it has gone up. There could be a few things that you may need to put in place. I had an experience with a 9-year-old girl whose viral load previously was suppressed, and suddenly we noted that viral load was around 600, 700. It would never go below that. It was just like that, like 2 years we did that. So we decided to have a chat with the caregiver just to find out if there were any issues at home. And what we discovered was that she would skip maybe a day or two when she was given the medication by the maid. She would go and throw the drugs under the mattress. So one day when they were cleaning, they found a few drugs. So she would take some days she wouldn't take. But the viral load never went above 1,000 copies. It was at 700. But this is a child who was previously 0 copies. So something that we need to look at and also just strengthen monitoring, and also, if possible, provide enhanced adherence counseling for such clients. So what have we learned in this session? What have we discussed? The aim of ART administration in children is to suppress HIV replication and halt the disease progression while reducing opportunistic infections and morbidity. Viral load suppression is an essential parameter of ART effectiveness as a surrogate marker for disease progression. Do not delay optimizing the ARVs by waiting for genotype results. The following strategies can help achieve viral load suppression in pediatric recipients of care: screening and treating for opportunistic infections, age-appropriate disclosure, EAC, DOTS, and case conference.
Wow, thank you very much, Dr. Manzi. That was a very packed presentation and very timely. Indeed, we do have children and adolescents that we seem to be struggling with in terms of suppression. You can imagine having a high viral load for over 2 years. That shouldn't be the case. But I think we've learned some of the factors and some of the things that we should consider, and we hope that in our facilities we'll be able to implement what we've learned from this presentation. So before we go to our questions, we are going to relaunch the poll questions. IT, could you please assist us with relaunching the first poll question? So the question is, by the end of Q4 in 2023, Zambia achieved viral load suppression among children 0 to 14 years old. So this is in line with the 95, 95, 95 that Dr. Manzi talked about. Is this statement true or false? By the end of Q4 2023, Zambia had achieved 95% viral load suppression among children 0 to 14 years old. Okay, we can end the poll. Okay, thank you. So like we learned, majority of us think the statement is false, that's 77%, but we still have 23% of us that think this is true. So Dr. Manzi.
They joined the meeting late.
Yes, we could have some people that joined the meeting late. So maybe you'd like to emphasize on the answer?
Yeah, so if you are looking at maybe the province where you are coming from, you could be doing well. But by end of Q4, the viral load suppression among children 0 to 14 was at 85%, not 95%. We still have a few children that are unsuppressed for us to achieve the 95%.
Thank you very much. We can move on to the second poll question. The question reads, the following can contribute to unsuppressed viral load in a pediatric client. IT, kindly assist with the second poll question. The following can contribute to unsuppressed viral load in a pediatric client. Is it A, poor adherence, B, drug resistance, C, toxicity to the ARVs, D, caregiver knowledge, E, all the above? So now that we've learned, we won't take much time, so we can end the poll. Okay, this is wonderful. So 96 of us think all the above is the answer. We still have 1% that think D is the answer, caregiver knowledge, and we still have 2% that think poor adherence is the answer. So Dr. Manzi, would you like to comment?
Yes, so even those who picked poor adherence and which one was that, caregiver knowledge, they were correct. Mm-hmm. Drug resistance as well. So it's all of the above. So all these factors can contribute to unsuppressed viral load if not taken care of. And we did discuss poor adherence is one of them. Drug resistance is a possibility, especially for those that have been exposed to ARVs as part of the EMTCT toxicity to the ARVs, and also the knowledge by the caregiver who's giving. Are they giving correctly? Are they giving the correct dosage, correct time, and things like that? So we also have to look at compliance and adherence. in terms of caregiver knowledge. So all of the above was the correct answer.
Great. So we have our third poll question. IT, you can launch it. So it reads, Upale is 11 years old and has been on ART for 9 years. He has a viral load of 4,500 copies per mil. During enhanced adherence counseling, he tells the provider he is not sure why he has to take medication every day. Which of the following strategies will not help Upale achieve viral suppression? I repeat, which of the following strategies will not help Upale achieve viral suppression? I think if we're concentrating, Dr. Manzi emphasized on this. I'll allow a few more seconds. We only have 27% of our participants that have participated in this poll. Upale is 11 years old and has been on ART for 9 years. He has a viral load of 4,500 copies per mil. During EAC, he tells the provider he's not sure why he has to take medication every day. Which of the following strategies will not help Upale achieve viral suppression? Okay, at least we have a good number that have polled. We can end the poll. So we have majority of us that think B is the answer. Referring him to a support group will not help. We still have 29% that think screening for opportunistic infections is the answer. 4% think using DOTS, and 13% that think continuing EAC with the caregiver. So Dr. Manzi, we see some split votes, but I think majority of us think the answer is B. So you can just give your comment.
Yeah. Thank you so much. I know that even in the exam, there are always questions, or there's always that one question that confuses you. And as I was preparing the presentation, I told myself I need to just assess what people think about support group and adolescents non-disclosure. So this really is a scenario that is speaking to us about our practices. Mm-hmm. Would you send an adolescent who's not disclosed to a support group and they have a high viral load? No. So it starts with disclosure. So once we've achieved disclosure, then we can send him to a support group. We need to continue with the EAC. That one we need to, with a caregiver, because the caregiver knows the HIV status. We can use DOTS in this case where we observe him taking the drugs. And we screen for any opportunistic infections that he could probably have. But please do not refer adolescents who do not know why they are taking ARVs or who have not been disclosed to support groups. It actually discourages them. And if they discover that they are taking ARVs, that's why they are going to that support group. It makes the situation worse and they may even stop taking the ARVs.
Thank you so much, Dr. Manzi, for that wonderful presentation. And we've now come to our question and answer session. I know we do have some questions in the chat. Okay. Network, I understand we do have some questions in the chat box.
Okay, raise your hand.
Okay, so you can raise up your hands and I'll give you the opportunity to ask your questions. Okay. So we do have some questions in the chat box. We have a question from Blessed K asking how many facilities in Zambia do genotype. So we'll take maybe 3 questions at once, then you can just take note and answer. Okay, so there's another question. What is the turnaround time for genotype? Then we have Dr. Rachel Thomas. Okay, she was able to answer some of the questions in the chat box. So drug resistance testing is done at UTH and at the Davison Children's Hospital in Dola. So that's 2 labs. And the average turnaround time is 1 month. Thank you very much, Dr. Thomas, for answering that question. Okay, we have something from Kazanga. Kindly advise on dispensation of clients with low-level viremia. Do we dispense as a stable client, that's 3 mmD for PIDs, or may we consider dispensing monthly? Kindly advise. Then we do have Dr. DS just commending you on the wonderful presentation. Okay, Dr. Thomas has been able to respond to the question. She says, we make sure adherence challenges, if any, to be corrected, no EAC. We can give 3 mmD and repeat viral load after 3 months. Okay, we have Chansa also just thanking you for the wonderful presentation. Okay. So we have Vanek who says, enlighten me on disclosure and when it must be conducted and what specific age should be considered or criteria to use when applying it. So maybe Vanek missed that part of the presentation. So I think I'll allow you to answer this question, then we'll allow the network to ask their questions.
Thank you so much, Dr. Lungwebungu. So disclosure, we have partial disclosure and full disclosure. And in partial disclosure, we just tell the child that they have a disease and they are taking medication. They have to take their medication to remain healthy. So we are using a soft language. And it coincides with the age around when they are starting nursery or grade 1. So I would say grade 1. 5, 6, somewhere there, you just, speak to them about why they need to be taking their medication without mentioning the word HIV or telling them they are living with HIV. And then in full disclosure, the child should understand that they have HIV and they have to take the medication to keep themselves healthy. And we're expecting that this child, by the time they are 13, 15, they have achieved full disclosure. So for further information, you can refer to the 2022 Consolidated HIV Guidelines. We have a page, I can't just remember the page number, that even has a picture of the disclosure process, okay? So it has the 3 stages indicated, so you can get clarification from there. So like I said, the age should also go with the development of the child. So we have children who maybe have delayed development due to delayed starting of ARVs. So this child who's 10, 11 may be behaving like a 5-year-old. So you may not achieve full disclosure by that. So the 2 go hand in hand.
Thank you very much, Dr. Manzi, for answering that question. So we have a question from Blessings Museva who says, what can you do? What can you do if the child is always having a high viral load despite doing everything right? So Dr. Thomas has said, if everything is right, think of drug resistance testing, but most of the time, adherence barriers should be reassessed. And I think this speaks to Dr. Manzi's presentation where she said, most of the time, it's really issues to do with adherence. Okay, I hope, Museva, that answers your question. We have a question from Dr. Namata from Mongu. What is being done to improve the turnaround time for drug resistance testing, especially for provinces being serviced by UTH? what is being done to improve the turnaround time for drug resistance testing, especially for provinces being served by UTH. Then we have another question. You can tackle them at once. Enlighten me on disclosure and when, okay, I think we managed to answer this one.
Something more on who does it and when. Yes.
How best can you advise on peds who were switched to second-line treatment without being screened for genotype or drug resistance? How best can you advise on peds who were switched to second-line treatment without being screened for genotype or drug resistance? So you can answer these two questions.
Okay.
Hi, Dr. Mansi. Good afternoon.
Good afternoon, Dr. Thomas. Maybe you would...
Can I answer? Can I answer the drug resistance delay at UTH?
Yes, you can to that one, Dr.
Yes. Yes. Most of the time, what happens is that the province says UTH is delaying the drug resistance. But upon investigating the matter, we find the sample 99% of the time, the sample hasn't reached UTH. So my advice is, even it happened in Eastern Province, last time we were given a list. So I discussed with the team here. They said they never received those samples. So maybe the hub site from each province should track their sample. Has it reached UTH? If the sample has arrived at UTH, it takes only roughly a month if our machine is okay and if we have the reagents. Of course, if you have shortage of reagents or the machine problem, it may delay, but they can always check the people from the province, what is the status, because they can always track their result. Yeah. So make sure that sample has reached UTH. Yeah. Thank you.
Thank you very much, Dr. Thomas. You can answer the second one.
Thank you so much, Dr. Thomas. So there was a question, I think, that was still asking for more information on disclosure and how the process is done. And I've seen there is another question in the chat that is talking about disclosure being done to a child with a high VL and the viral load is still high. So disclosure, it's not the duty of the healthcare worker to disclose the HIV status to the child or to anyone. But it's our duty to provide disclosure counseling where we guide the caregiver on what they need to do to disclose. Unless they choose to say they would like you to be there as they disclose. We've had cases where the caregiver discloses the HIV status, next the child goes to attempt suicide because it was done at home. So they would rather it's done at a facility where if there are any questions, the caregiver is able to, the healthcare worker is able to respond. So we start with the caregiver, we talk to them about the need to disclose the HIV status to the child, and then they can do it either at home or if they are not comfortable doing it on their own, they want to do it in your presence, that is still okay. But it's not you to tell the child that they're living with HIV. We should never do that. So I just wanted to add, and the age, we've agreed that we start around the age of 5, 6, with soft information about chronic illness, why they need to take the ARVs to keep healthy and things like that. Then we start to change the language as a child is growing older, and we're hoping that we can achieve full disclosure by the time they are 13. I mean, these are adolescents who are already sexually active by then. Some of them, their sexual debut in Zambia is at the age of 10. So by 10, some of them are already sexually active. And if they don't know that they're living with HIV, they may transmit or they may get another virus, okay, even a resistant one. Switching to second line before genotyping, what can we do? You've already switched this child to second line. I'm not so sure how old this child is and which second line they are on. So like we said earlier on, there are situations where you switch to second line, you've collected, or the guidance is that when you receive a high VO after completion of EAC with optimized adherence, you collect a sample for genotype and switch to second line. When you receive the results for genotype, you will look at the genotype results, and that's what is going to guide you on which regimen you are going to choose for the child. But in this case, maybe what could have happened is we just switched, we didn't collect drugs for genotype, and the child is very suppressed. Okay, the issues were addressed. What would we do? For me, I feel we can still continue with the second line, unless otherwise we have results that have shown that the child is still susceptible to the previous drugs that we were using, then you would still maintain on those drugs. But the guidance is that we maintain that second line. Yeah. There was another question. Did we read that question? Not yet.
Okay, so we have quite a lengthy question from Dean Musonda Chinyanta. So they're saying they have a child who's now 15 years old and has been unsuppressed for quite some time. They've talked to him and disclosed the status in the presence of the guardians, but this child has 2 homes. So it's posing as a challenge in terms of adherence because the child is in 2 homes. They can't really monitor well. So,
Hi, Dr. Mansi, can I try that one?
Sure, Dr. Thomas, you can go ahead.
Yes, that one, the 2 homes. First, we educate the caregivers in both homes about the importance of adherence and also to the ROC. What will happen if he is not adherent? Usually, when they say they are very adherent and the viral load is not getting suppressed, I open the smart care, show them the graph of the viral load. So I usually ask them, what happened when it was high? If it has ever come down, what happened? They will answer themselves. They are not taking the drugs. So if you have a good rapport with the client, they will answer. And also, from 11 years and above, we want our children to take responsibility for their medication. So usually what we tell the caregivers is, when it is time for the medication, the child should take the medicine himself or herself and swallow it in front of an adult caregiver. Their job is to make sure they saw the child has swallowed the tablet, not going and spitting. So, and after we tried all these things, and of course, the education of the consequence of high viral load, like in future, the viral replication and the inflammatory process can damage the organs like the brain, the kidney, the heart. We educate them all the consequences what they may face, the eyes, everything. Then, if you have a good relationship, they will change and then repeat the viral load. If it still comes high, then do drug resistance. Then the result comes, you see no resistance, all the drugs susceptible. I will just tell the client and the caregiver, we wasted a lot of money to do this test to show that you were not taking the medicine. So we just assessed the adherence by doing the drug resistance. We know there are certain clients, even in our setup, they always have high viral load, get suppressed, again back. So we also have such clients, but we need to educate both the client and the caregivers about the consequences of what they are doing. And then again, we should make our adolescents responsible for their health. They should take responsibility for their health. So usually I ask them a question. They know the knowledge is there. What happens if the viral load is high? They know the CD4 goes down, they get sick, they die, they say all sorts of things. Then I will ask them at the end. So they know it. So if you get sick, who is going to suffer? Is it the parents, caregiver, or the healthcare workers? You make them aware of all those consequences. And we should instill in them the responsibility to take their health. Thank you.
Thank you very much, Dr. Thomas. Dr. Manzi, do you have anything to add?
Yeah, just trying to echo what Dr. Thomas has said. Dr. Thomas has got a lot of experience working with children with high viral load at the UTH hub. And what she has shared is from experience. So yes, I want to agree that sometimes you just need to have a one-on-one with the adolescent and just show them the results. On the screen, you say, this is your viral load. You have the results for genotype, all the drugs are susceptible. You explain to them what that means. You say, here it shows that you are not taking the medication because this medication will still work. So if you continue like this is how you are going to progress, and in the end, you may die. I had a scenario like that, and it was a 15-year-old, the way you're explaining, was living with a stepmother and a father. So the stepmother used to tell him, if you don't take your medication, you will die and follow your mother. So he stopped taking the medication and said, I would rather die and follow my mother in the grave than live in this house. So they do understand that if they stop taking their drugs, something bad is going to happen. So you just need to explain to them the importance of taking the drugs. And you show them examples to say, if you live a healthy life, you can finish your education, you can be a doctor, you can be a lawyer. And also just try to give them that positive motivation so that they're able to know that people living with HIV can still live normal lives. Because sometimes they think being HIV positive is a death sentence. It's the end of their life. So they feel like if I stop taking the medication, I might as well just die and forget about living. So just being frank with the child in front of the caregiver and explaining to them the importance of taking drugs. The problem of non-adherence among adolescents is on the rise. We are seeing a lot of numbers, especially young adolescents, 10 to 14. So we just need to make sure that by the time they are in that early adolescence, they are learning how to take care of themselves and taking the responsibility of taking the drugs. Dr. Thomas did bring out again the issue of dots. The caregiver can be tasked to make sure that the child is swallowing the tablets. The moment a child is in adolescence, there's always that fight between the caregiver and the child. Sometimes they're defiant, they don't want to listen to the caregiver. So you just say, come and drink the medication until you are comfortable enough that they can go to a facility and pick the drugs on their own. But as long as they're not able to do that, you have to observe that they're taking the medication, especially when they have a high VL. So you just say, okay, come and take the medication, and you observe them taking the medication. So that is something else that the two caregivers taking care of this child may be supported with. Yeah.
And Dr. Mansi, can I ask a question to the facility?
Sure, Dr. Thomas, you can go ahead.
Yes, they said the child will be rebellious. Did you find out what is the cause for that rebellion? There may be a cause for that. The environment, whatever is his thinking. Because I had a client today, a 19-year-old girl. She said she's on air. She said she stopped her drugs for 3 months now. The reason being, her mother is late, father got married. The father is not taking care of her. She stays with her sister. So he is not sending her to school. So she is reacting rebellious to the father that he is not taking care of her. So did you find out what is the cause for that rebellion? Then we need to deal with that.
Okay, so Dean Musonda Chinyanta, we need you to answer that question. Are you able to tell us the root cause of that rebellious behavior? Because that could just be the solution to your problem. Dean Musonda Chinyanta, are you able to unmute your mic and just respond to Dr. Thomas' question?
Good afternoon.
I think.
Hello?
Hello, Dean.
Yes, good afternoon.
Good afternoon. You can proceed.
Okay, so the child's mother is late and the father remarried. So they usually have conflict with the stepmother, and when that happens, he runs to the auntie's place. That's where he would go and seek refuge. So, but we've tried to sit down both families, but still we haven't been getting any improvement.
Dean, Dr. Manzi has some questions for you. Thank you for clarifying that question that Dr. Thomas asked, but Dr. Manzi has further questions for you.
Yeah, so maybe Mr. Dean, what you brought out is a very interesting scenario, which is very common among adolescents. A lot of adolescents go through that. I've had scenarios like that. So maybe just to find out which district you are from and if you have OVC services, because like I said in the presentation, OVC team also come through either to do a case conference for this child as an intervention that can help us come up with a solution. There are cases where in the case conference, you discover that none of those two homes want to keep this child. And at the end of the day, you have to go social welfare and possibly take this child to a safe home. So have any of those interventions been considered? Do you have OVC services in the district or at your facility? And any case conferences done to come up with a solution for this child staying in the two places, which is affecting his adherence to treatment.
All right, thank you. So we engaged the ICAP guys and they made the follow-up, but then the child has been dodging them every time they go there, like I mentioned earlier in my question. So the child is always running away from them whenever he sees them. And like I said, because of the two homes, at times they'll tell him it's okay, he's at this house. They go there, they don't find him. And just that keeps happening. When you spot him in the street, he'll still tell you to say I'll be coming, but he disappears. Otherwise, this is Shirirabombwe, specifically Kakoso Level 1 Hospital.
Thank you so much. It would be good also for the community team just to find a way of engaging these adolescents. I know if you are talking about ECAP, the Northern region has got ECAP too, I think. In this side of the country, we have ECAP 3 that is supporting some of the provinces. So if they do, the caseworkers will probably have a way. If they may not reach to this adolescent, they can use community adolescent treatment supporters. So these are adolescents that are living with HIV and they use their own experience to talk to these adolescents. That's another opportunity that we can use. I've used adolescents living with HIV to reach out to adolescents who stop treatment. And then we just engage another adolescent living with HIV to have a chat with them. They may understand or listen to this person because they are experiencing the same things rather than a healthcare worker who may not experience what they are going through. So that could be another way to engage an adolescent living with HIV to have a chat with this adolescent. Yeah, so a lot of suggestions have been made. We could still go sit on a table with the ECAP team and the caseworker so that we come up with a lasting solution to help this young man. Just make things clear to him to say, if you don't take your treatment, this is what is going to happen.
Thank you very much, Dr. Manzi. Dr. Thomas, would you like to also give your comment and thoughts as to what they can do next with the given information we have so far? Dr. Thomas? Dr. Rachel Thomas? Are you able to give us your thoughts on this case and how they can proceed with the given information?
Hi, can you hear me?
Yes, we can. You can proceed.
Okay. Yeah, one thing I want to mention is vomiting the drugs soon after it is given. Within 30 minutes, if they vomit, the caregivers are supposed to repeat the ARVs. Sometimes that information is not given to the caregivers and they don't repeat. Recently, we had a case, intermediate resistance, secondary to not repeating the drugs. So we need to inform the caregivers if these ARVs are vomited within 30 minutes of intake, they should repeat the dose. And also, as healthcare workers, drug interactions, we need to make sure if we are giving DTG with rifampicin-based ATT, to give it a BD, the DTG, until 2 weeks after stopping ATT. Just wanted to mention those. And sometimes we see the situation, there are multiple caregivers bringing the child to facility, and some of them are not even aware of the status. Last month, I had an adolescent bringing a 3-year-old. The mother goes out for business. She doesn't know why she is bringing the child. And you know the difficulties with such situation. I just wanted to mention a few of those which will contribute also to the virological failure. Thank you.
Thank you very much, Dr. Thomas. I don't see any hands raised and we don't have any more questions. Dear Network, do we have any burning questions as we wrap up?
One more thing. Thank you, Dr. Mansi, for the great presentation. Thank you.
Thank you, Dr. Thomas.
Network, do we have any more questions? Okay, I don't see any hands raised, and I think we've addressed the questions that we had in the chat box. So at this moment, I just want to ask Dr. Manzi to give her final remarks as we wind up.
Thank you so much, Dr. Lungwebungu. And thank you to ECHO for the opportunity to share on management of unsuppressed viral load in children. We've seen that in achieving the 95, 95, 95, for the children, we're still lagging behind in almost all the three. We will not achieve ending AIDS by 2030 if we don't ensure that every child who's diagnosed with HIV is on treatment, is virus suppressed, because we'll see a generation of these children and adolescents growing into young adults and transmitting the virus to their generation. The rise of unsuppressed viral load among adolescents due to non-disclosure, non-adherence is something that we need to address. It could be caused by a lot of factors which could be addressed during adherence, during case conferencing, and we can use other strategies like DOTS, just to make sure that we are observing that these children and adolescents are taking ARVs. Let's not delay to optimize the ART by waiting for the genotype results, but let's also have a system in place to track these results. I know Dr. Thomas said 1 month, but you can get the results within 5 to 10 working days, as long as you have a system to track those results. So the lab coordinators at provincial level, I think if you put a bit of pressure on them, you can get your results on time. Sometimes the results are there sitting in the lab, but they are not transmitted where they are supposed to go. So let's also be proactive from our end as healthcare providers. Together we can end AIDS by 2030. Thank you so much.
Thank you. So we do have some last comments in the chat box. I think this is just to appreciate you for your wonderful presentation and for the facilitation. Thank you, Dr. Himawala. Thank you, Dr. Namata. He says, great presentation, very insightful. So at this moment, I'd just like to thank you all for logging in to our Monday Echo session. You've been a wonderful network. You were able to participate in the poll questions, and it was indeed a very, very interactive session. Thank you to you, Dr. Manzi, for your expert input. That was a very wonderful presentation, and we understand you took time to prepare it. We just want to appreciate your expert input in the HIV program, particularly in the pediatric population. Dr. Thomas, we want to appreciate your expert input and your experience dealing with children, with living with HIV over the years. We just want to appreciate your input in today's presentation, and you were able to answer the questions in the chat box and the ones that were asked. I'd like to appreciate Chatonda for assisting us with IT, and I also want to appreciate Kunda, who was able to coordinate our session. Otherwise, from us in the hub, we say thank you and have a lovely week. Goodbye.
Bye.
Bye. Thank you.
Bye.